In this lecture, we're going to talk about sensory receptors. Recall there are three main functional classes of neurons. Motor neurons that send action potentials to your muscles to cause them to contract, or to glands to stimulate secretion, for example. There are interneurons which reside within your brain and spinal cord and process information coming from the environment and also commanding your motor neurons. And then there are your sensory neurons, whose job is to respond to stimuli in the environment with action potentials and to send those to your brain and spinal cord, to your interneurons, to be interpreted or processed. So that is the job of sensory neurons. Now these stimuli are going to be coming from the environment, either from outside your body, so things like touch and pressure and temperature and light and sound and chemicals in the air and food. Those are all could serve as stimuli. In this picture they're showing cold as a stimulus, temperature. But whatever the stimulus is, it's going to trigger graded potentials or receptor potentials in the dendrites. So here we're looking in this top picture at a sensory neuron. Recall that sensory neurons are not multipolar like motor and interneurons are. They are uni or bipolar. So in this picture we are looking at, here's the cell body, and notice there is one process coming off the cell body. So this is a unipolar neuron, and then it divides to form the axon, which we see in this case is myelinated. See the myelin sheath on it. So all of this is the axon over here too. And then at one end we have the dendrites. That is the sensory receptor end. That is where the stimulus triggers graded potentials, which are going to travel to the beginning of the axon here. And if strong enough, will trigger action potentials. So the minimum you need for a receptor, for a sensory receptor, are the dendrites of a sensory neuron. Okay, and the stimulus is going to cause graded or generator potentials by opening ion gates. And depending on whether those ion gates produce depolarizing waves of positive charge that travel to the beginning of the axon and may, if strong enough, trigger action potentials, or whether they cause hyperpolarization, a more negative charge traveling to that same region where action potentials will be inhibited. It's all going to depend on what kind of ion gates that particular sensory receptor has. But the main point is that environmental stimuli, either from outside or inside the body, trigger these generator potentials in the dendrites, and that is really at the heart of what a sensory receptor is. Now we'll see some cases where there will be a lot of other cells in addition to these dendrites of sensory neurons that form the receptor, but they are really the basis of it. In this lower picture we see a slightly more complex structure. We see a unipolar sensory neuron whose dendrites are wrapped with some connective tissue. So we say they're encapsulated. Okay, but otherwise it's the same principle. You need the dendrites where the generator or receptor potentials are going to be triggered by the environmental stimulus. Here's the skin, which is a good place to look for examples of both of those that we were just talking about. So for the free dendrites of sensory neurons, or we can call them naked dendrites, here are some examples in your skin. Here's a touch receptor. So you see here the dendrites of the sensory neuron. Here would be the beginning of its axon. Where is its cell body? Well, it's far away. It may even be up in the dorsal root ganglion near the spinal cord. Here's another example. Look at these dendrites here wrapping around this hair follicle. This is called a hair root plexus. So those are dendrites, and when the hair is brushed, it will move the hair in the follicle and stimulate this sensory receptor. And then here's one more example of just a plain old bare dendrites, a nociceptor or pain receptor. Notice how it's up there right in the upper part of the papillary layer of the skin. So if you were to get a splinter or something, those dendrites are going to respond. And then we also see some encapsulated examples, like this type 2 skin touch receptor has some connective tissue around it, or here's something called a Pacinian or laminated corpuscle. It's got connective tissue wrapped around it. So lots of those two types of sensory receptors. So based on what the actual sensory receptor is made of, there are three basic structural classes. We just looked at the first two. The free nerve endings, in other words, just the dendrites without anything around them. The encapsulated dendrites is the second. And then the third type, based on structure, is far more complex, where there are going to be additional cells associated with in the receptor. So, for example, here's one of the most complicated sensory receptors. We have the eye, and in the eye, which we'll be covering in a later lecture, but in the eye there are many types of tissues. There's smooth muscle tissue, there's nervous tissue, there's connective tissue, and the actual sensory receptors that respond to light are only found in the innermost layer called the retina, this thin yellow layer on the inside of the eye. It doesn't even extend to the front of the eye. It stops around here. So that's where you find the sensory receptors, but there's so much more associated with the eye. So that's obviously far more complicated than bare dendrites. So that's an example of the complex receptor. The ear would be another one. Okay, and then another way to classify sensory receptors that's useful to think about is where the stimulus is coming from. In other words, is it coming from outside the body? If so, we call it an exteroceptor. If it's coming from inside the body, it's an intero or visceroceptor. Okay, so for example, your eye would be an exteroceptor. It's monitoring the external environment. Your ear would be an exteroceptor. The receptors in your skin would be exteroceptors. Interoceptors would include things like blood pressure, receptors inside your body, pain receptors associated with your visceral organs. And then there is this third class called proprioceptors. These are located in your skeletal muscles, your tendons, joints, a part of your ear that we'll be talking about in our next lecture called the inner ear. These sensory receptors provide information about the position of your body in space. So in addition to literally looking at your arm to see where it is, or your leg, we have, in addition to that, proprioception, where you can sense the position of your body in space using these sensory neurons. They monitor things like muscle length. When you move at your synovial joints, you've got some proprioceptors there, so they respond to joint movement. So that's the third class. I'm going to show you a diagram which has some proprioceptors in it. So here's a skeletal muscle, and then here's a tendon that's coming over and attaching to a bone. Okay, and we have proprioceptors both in the muscle. So if you look at this blue neuron and this yellow one, these are both sensory neurons. You know, usually we're used to talking about motor neurons when we talk about muscle, and most of them are motor neurons. But there are some sensory neurons. And notice how they come in to the muscle and they wrap their dendrites around some of the muscle fibers in the muscle. So when you contract and relax your muscle, it's going to stretch, you know, mechanically stimulate them, and it will generate nerve impulses, action potentials that are going to go away from your muscle to your central nervous system to be processed, sensory input. Here's another example of a proprioceptor. This one is in your tendon, and this is an example of an encapsulated one. It's got a connective tissue capsule around it. So again, when you're moving your muscles, it's pulling on your tendons in order to move your bones as levers at your synovial joints, and that's going to stimulate these sensory receptors, these sensory axons will carry action potentials to your CNS. Okay, and then here's yet another way to classify sensory receptors. All of these are very useful for understanding, in general, sensory receptors, where they are, what they're responding to. So in this classification, we're dividing up the sensory receptors based on the type of stimulus what kind of stimulus are they detecting? You know, is it chemical? Is it temperature? And so on. So based on the type of stimulus, I would say there are three in this list, three fundamental types of stimuli that, and remember what these stimuli are doing. They are opening ion gates to cause receptor or generator potentials in sensory neurons. So the three basic stimuli are mechanoreceptors. In this case, the ion gates in the dendrite are open due to mechanical deformation of the dendrite. So like touch or pressure or vibration, blood pressure. All of these physically distort the membrane, open the ion gates, and we call them mechanoreceptors. Even hearing, we'll explain this more when we get to the ear in our next lecture. We'll cover the eye and the ear separately. But these are all examples of mechanoreceptors. Even the proprioceptors we were just talking about, because they respond to the movement of muscles and joints. So notice that some of these are interoceptors, like blood pressure receptors, or receptors that monitor stretch of your internal organs. Others are exteroceptors, like touch and pressure receptors in your skin. So there's all different types of mechanoreceptors in the body. Another fundamental one are the thermoreceptors that respond to temperature changes. You have both intero and exterothermoreceptors. So in your skin, you have separate hot and cold receptors that monitor things like air temperature, or if you touch a surface, or water, is it hot or cold? Those are exterothermoreceptors. And then you also have thermoreceptors inside your body that monitor your internal temperature. For example, remember when we talked about the hypothalamus and how it's a thermoregulatory center? So it's going to rely on thermoreceptors to provide the information about internal body temperature. And then another, I said there were three. There's actually four basic kinds of receptors. Photoreceptors in the eye. In humans, they're only found in the eye. And they respond to light. So light is the stimulus. Photons in light, hence photoreceptors. And then there's a huge class that respond to, or their stimulus are chemicals. Those are called chemoreceptors. Very large class. So some chemical is going to open the ion gates for those sensory neurons. So these could be exteroceptors. For example, putting food into your mouth. You taste various chemicals in it, smells in the air. But we also have interoceptors that are chemoreceptors, like monitoring concentrations of various things in your body fluids. So, mechanical force, temperature, light, and chemicals. These are the major kinds of stimuli that excite nerve impulses in sensory neurons. Now, we're also going to talk about nociceptors. Nociceptors are pain receptors. Okay, they're your body's pain receptors. Nociception means reception of pain, perception of pain. But they are not a completely separate class from the four we just mentioned, because notice if you look over here at what nociceptors are responding to, they're responding to physical damage. So say you press really hard on your arm, the skin on your arm. If you press hard enough, it'll start to hurt. Okay? So that's a mechanical stimulus. Or chemical damage. So you would be responding to chemicals like chemoreceptors. So for instance, when you have tissue injury, say you get a bad cut, there will be some chemicals released from the damaged tissue cells that will stimulate pain receptors. So, that's acting like a chemoreceptor. So my point is that pain is not a completely separate kind of stimulus. It's usually, a mechano or a chemo stimulus, chemical or mechanical. And it could also be thermo, very hot temperature, or even photo, an extremely bright light shown into your eye would be perceived as painful. Okay, and then there are osmoreceptors, and osmoreceptors I would describe as a combination of chemo and mechanoreceptors, because osmoreceptors are inside your body. They're interoceptors, and they're monitoring the osmotic pressure of your blood and your other tissue fluids. And recall, osmotic pressure means the total solute concentration in your body fluids. And that's a big deal because it influences water movement by osmosis. So recall, water moves from areas of lower to higher solute concentration. And so it's a big deal. For example, the osmotic pressure of your blood. It matters a lot. You don't want it to be too high or too low, because you're going to either pull water from your tissue fluids into it, if it's too concentrated, or if it's too dilute, you're going to then water can move in the opposite direction by osmosis. So we need to monitor the osmotic pressure, especially of our blood. So we do have osmoreceptors, but again, that's not a completely separate kind of stimulus. It's a chemoreceptor, and then it's responding to solute concentrations, and also it's acting like a mechanoreceptor in that it's sensing this pressure, the osmotic pressure, where water will move from lower to higher solute concentration regions. So let's talk a little more about nociceptors. So pain usually is, talked about in a negative way, understandably, but actually pain does have a purpose. So we need pain because it's our warning. It tells us stop or slow down or something's wrong or seek help. Say you sprain your ankle when you're running. If you don't feel anything, you might just keep running and making the injury worse and worse. Or what if your appendix is ruptured and it's spewing things into your peritoneal cavity and you need to go to the doctor and have it addressed? Well, you're going to get there a lot quicker if you're in pain. So pain is, a useful message. It's a way we talk to ourselves and say, hey, better do something about this. So pain is an interesting topic, and I did want to talk a little bit about it since a lot of you are going into the medical profession. So here are the three main types of pain that they talk about. Superficial somatic pain is coming from pain receptors or nociceptors in your skin. Deep somatic pain is coming from pain receptors in your muscles, skeletal muscles, your joints, your tendons, your ligaments. And then visceral pain is coming from your visceral organs, your kidney, your stomach, your pancreas, etc. Okay, so those are, different sources of pain. And they're perceived differently. Superficial somatic pain is usually felt as very sharp pain, like a paper cut, whereas deep somatic pain is often more of a dull but aching, throbbing kind of pain, like when you have a backache, muscle pain from overwork or lifting up a box incorrectly or something. And then visceral pain is harder to characterize, but it tends to be felt more like deep somatic pain. Now, if just to go back for a moment, and we're not really concerned with this one on the right, the motor area, but if we could just review for a moment the primary somatosensory cortex in the cerebrum. So if you recall, when we studied the brain, we talked about how the cerebral cortex has this region where we localize sensory information coming from the skin, or really somatic sensory information from our skin and muscles and joints in these different regions of the body. This is the homunculus map that we talked about. And we talked about how, for example, our hand looks very large in this map because we devote a lot of, these would be interneurons in here in the cerebral cortex. They are devoted to receiving sensory information from the hand, and you see that we have a lot of sensory receptors there. Same in the face, and then other parts of the body, like the trunk, which is a large area, has relatively much smaller area of the cortex devoted to it. Anyway, one of the main things the primary somatosensory cortex allows you to do is to localize sensory information coming sensory input from the opposite side of the body. So it allows you to localize it, to say, oh, that's something bit my left forearm. You can localize the pain. Notice in this picture, do you see any spleens or kidneys or hearts or livers? No, because the somatosensory area maps the skin and muscle part of the body and not the viscera. But there is a theory, I guess you could call it, that a lot of our visceral pain sensory nerve impulses somewhere along the line synapse with axons of neurons carrying somatosensory information from the skin, your skin or muscles, for example. So somewhere along the line they synapse, or they converge, and they end up going to the same region of the primary somatosensory area. So this theory is to try to help explain what we call referred pain, where in many cases pain coming from your viscera, say from your heart or from your kidney or something, the theory is that those nerve impulses don't have their own area of the cortex where they can go and you'll say, oh, my pancreas hurts, or oh, my kidney feels funny. Instead, the theory is that those pain impulses again go to the somatosensory cortex and then are perceived as somatic pain. And if the pain is coming from a region different from the place where it is felt by the person, then we call it referred pain. Not all pain is referred, but that is what referred pain means. Pain that originates in one place in the body but is felt as if it's coming from a different location. And for visceral pain, there are numerous examples of referred pain. So this is the picture showing some of those major regions. And it's something that would be good to be familiar with if you're working with patients who are in pain, because it's something you have to consider. If a patient says their back hurts or their shoulder hurts, you want to at least consider that perhaps it's not a muscle pull or strain or something like that, but it could be coming from an internal organ. So, for example, we all know the classic referred pain of a heart attack, where pain is felt in the left chest and radiating down the medial part of the left arm. Okay, that's not always going to happen with heart attacks, but that is a common referred pain that is felt by people having heart attacks. Okay, so I think most of us know that one. And I think it's also pretty common knowledge that lower back pain could actually be coming from nociceptors in the kidney. Okay, but there are some others that you might be interested in looking at. You see this neck region in green here could also be referred pain from the lung and diaphragm, which is way down here. So, hence referred pain. Or look at on this side, could be liver or gallbladder pain. So referred pain is definitely something to be taken into account when working with patients. Okay, and there was one more thing I wanted to say about pain, and that is that pain is a very personal in the way it's perceived. There's a lot of variability between one person and another, and so I hope that when all of you are set in your career and you're working in hospitals as nurses or doctors or sonographers, etc., that you'll remember that about pain, that it's a very personal thing, and what may be very painful to one person, the same, what appears to be the same kind of stimulus or level of assault on the body might be perceived very differently by someone else. So try to keep that in mind. When I worked in a hospital long ago to put myself through college, I worked with some in a children's hospital, and I noticed a lot of especially the more experienced nurses seemed to be more susceptible to this issue of where they started thinking they could intuit the level of pain that someone should be in, because they did have a lot of experience and they did know sort of the average time it took to recover from this or that operation, or how long some pain medication would usually be effective in a patient. But you can't make a blanket assessment on that. And so it was too easy for them to sometimes dismiss pain in a patient because that patient, perhaps the pain medication didn't work as well, or the surgery was giving them more pain. So there's a famous saying from one of the pioneers of pain management. McCaffrey is her name. At the moment I can't think of her first name. Margot, I think, McCaffrey. And it's very simple, and it's just that pain is whatever the person experiencing it says it is. like how painful it is. It's whatever they say it is, and it's happening wherever they say it does. Now, that does not mean that sometimes people don't exaggerate their pain. Maybe they want more pain medication or attention. I'm not saying, that you must always believe that, but it's where you have to start anyway. You can't assume that you know what someone else's pain is like. So, you give them the benefit of the doubt, at least until you have further data to perhaps persuade you otherwise. Okay, now I wanted to cover two more things here. What we just talked about, those sensory receptors are what we call general senses, in that they're more or less, pretty widely distributed in the body. Not that they're everywhere, but they're widely distributed, like touch receptors. They're widely distributed throughout your skin, for instance. So we call those general senses. And then there are some what are called special senses, and they are some of our most important ones. But in this case, special also means that they're localized. They're just in special regions. They're not widely distributed in the body. So we have 4 special sense organs: the smell, taste, the eye, and the ear. So I am going to cover smell and taste now, and then the eye and the ear will be in a separate lecture. Okay, so let's look at olfaction. This is your sense of smell. First of all, you do need to know where your sensory neurons are that are involved in smell. Where are they located? So if you look inside your nasal cavity, they're up in the roof of your nasal cavity. That's where they are. They're not on the laterally, they're not inferior. They're in the roof of the nasal cavity in what they call the olfactory epithelium. So here it is. In this picture we can see it a little better. You do need to know all the different kinds of cells that make up the olfactory epithelium. The most important being the olfactory receptor cells. So they're in blue here. These are sensory neurons. They're bipolar. See, here's the cell body with the purple nucleus, and then you see 2 processes coming off. A dendrite coming down and with little hairs sticking into the nose, and then the axon on the other end. So bipolar. These are bipolar neurons. Anyway, those are the olfactory receptor cells. As air comes through your nasal cavity, there are odorant molecules in the air, molecules, and some of them bind to these, they call them hairs. They're actually like extensions of the dendrites, but they bind to those so-called hairs and cause the graded potentials in the dendrite. It then travels up the dendrite, across the cell body to the beginning of the axon, where, if strong enough, it'll trigger an action potential. So those are the most important cells. Now, unusually, because this is a neuron, and the dogma used to be, no longer, but used to be that neurons are amitotic. They don't divide by mitosis, but we're now finding that that's not always true. I mean, they're not the best at being replaced. Like, they're not like epithelial cells, but some neurons are replaced, and here's a good example. You have basal cells in your olfactory epithelium, these little triangular blue cells, and their job is to periodically start to differentiate into new olfactory receptor cells, and the old ones are removed. So we do replace them every several months. So basal cells replace old olfactory receptor cells. So they're in the olfactory epithelium, so that's 2 cells. And then we have these orange cells here. They're called supporting cells because that kind of summarizes their function. These are epithelial cells. They're going to protect and support the neurons. And then, well, that's the olfactory receptor. Here we see a mucus gland in there, so let me a few of those. Okay, so that's the olfactory epithelium. They say that although we don't have as sensitive a sense of smell as, say, a dog or a wolf, we are sensitive to thousands of different odorant molecules. So we can discern quite a few different smells. This picture shows you what's going on in the sensory neuron membrane to trigger the generator potentials, the graded potentials in the sensory neuron. So this would be in the dendrite, and this is a chemoreceptor. And remember I said that chemoreceptors are where chemicals lead to opening of ion gates, like this purple thing here in the membrane. That's a sodium gate. So it's closed. Then this odorant molecule comes along and opens it, and sodium enters, and you get depolarization. Remember, that's how generator potentials are triggered, by opening ion gates. So in this case, it's a chemical that does it. Although notice it's not always direct. In other words, the odorant molecule, whatever that is not binding to the, sometimes they do, but it's not binding to the gate directly. It's binding to an enzyme called adenylate cyclase. So here it is binding to it. And when it does, it turns on this enzyme, which converts ATP to cyclic AMP. And then the cyclic AMP, that chemical inside the cell, acts on the channel to open it. So it's a little bit indirect, but you see the main picture here is that this odorant molecule is leading to the opening of ion gates. That's how it works. Once you get the action potential produced, the action potentials travel through, let me go back, I went too fast. Let's follow these axons of the olfactory receptors. You see how they come up, the axons, they come up and they go through the cribiform plate. I'm hoping you remember that from the ethmoid bone when we did the skull. Remember, it had a part of the ethmoid bone with lots of little holes in it, and so they're called olfactory foramina, and that's where the olfactory receptor axons go up through there. So that's how they get through the ethmoid bone. And then notice how they come up here into what's called the olfactory bulb. I'll show you another view of it in a minute. And they synapse with what are called olfactory neurons, olfactory bulb neurons. So there's a synapse here, and now we have a second neuron, the olfactory bulb neuron, and their axons travel along your olfactory tract. Now we call it the olfactory tract now because we're in the CNS. When you're in the CNS, you call bundles of axons traveling together tracts. When you're in the PNS, the peripheral nervous system, you call them nerves. So that's why we had to change the name from nerves to tracts. Here's, well, we'll look at even a better close-up in a minute. But here you see the olfactory bulb, and the olfactory tract comes along, and then from there the neuron axons go to the primary olfactory cortex of the cerebrum. That's where the action potentials need to go so that you can interpret that sensory input as smell. So that's where you perceive the smell, where you're consciously aware of that smell. Your primary olfactory area, it's in your temporal lobe of your cerebral cortex. So we call the pathway that the action potentials take from the olfactory epithelium to the olfactory bulb, along the olfactory tract to the primary olfactory area. That is the olfactory pathway. It's called the pathway that nerve impulses go from the actual receptor, in this case in your nose, to their final destination, your cerebral cortex. Here's a lot of text on here, but just look at this area right here. Here's the olfactory bulb. Oops, sorry, olfactory bulb, and then here's the olfactory tract coming along. And here's a close-up of it, olfactory tract and bulb in yellow. This is on an actual brain. They've injected it so you can see it better. Okay, so that's smell. Now taste is the other one I wanted to cover. Taste, as you already know from experience, is linked to smell in terms of when we taste food, we also use our sense of smell in addition to it for the overall experience of tasting food. As you know what it's like when you have a cold. You can't smell anything. It's harder to taste your food. It's not that you don't taste anything, but it's just not as robust of a taste. Or, you know, kids, if they don't like something, sometimes they'll hold their nose, so that does help if you don't like the taste of something. But we don't just use smell. We have actual taste sensory neurons. And most of them are located, not all, but most of them are located on our tongue. So if you look at your tongue in the mirror, stick out your tongue and look real closely, you see all those little bumps on it? Those are called papillae. Remember that word? You love that word in anatomy. Papilla, bump. So notice there's all different kinds, circumvallate, fungiform. Okay, we're not going to really get into that, but let's just say that some of those papillae contain taste buds. Okay, so in this picture over here, we see a papilla, a bump. You see those little blue balls on the sides? Those are taste buds. So they're on the lateral aspect of the taste bud, or of the papilla rather. And now we're going to look at down here a blow up of one of those little taste buds. So here you see a taste bud. And like the olfactory epithelium, you do need to know what kinds of cells are in there. So let's start out with how they're similar. The olfactory epithelium and the taste bud are similar in that they both contain support cells that support the receptor. And they both contain basal cells that replace old receptors. So that's similar. The main difference is in the receptor itself. Recall in the nose, the receptors were actual bipolar sensory neurons. They responded to the chemicals coming in through your nose with generator or receptor potentials. And then, you know, if they were strong enough, then their axons carried the action potential towards the brain. Well, in taste buds, it's a little different. The actual sensory neurons do not directly respond to the chemicals in the food or drink that you're putting into your mouth. Instead, there is a specialized, what's called a gustatory receptor cell. Gustation means sense of taste. So a gustatory receptor cell, and it does have little hairs that protrude into your mouth, gustatory hairs. They're kind of like, I think of them as like dendrites. And the thing about these gustatory receptor cells is that they're not true neurons. They do not have axons. So they're actually a modified epithelial cell that has dendrite-like hairs that do respond to chemicals in food with graded potentials. So, you know, they're like a sensory neuron with only dendrites. So that's the receptor cell. But like I said, they have no axon. So they have to synapse with a real sensory neuron. They call it a first order sensory neuron. But that's, so it comes in, and you see how it comes in and it actually synapses. Oops, sorry, that's very messy. Synapses with the receptor cells. So when a graded potential is generated in the receptor cell, it can pass it on to the real sensory neuron, where if it's strong enough, its action potential is going to leave through its dendrite. So in this case, it takes two to form to transduce the or to cause the chemicals in your food to produce nerve impulses. You got to have the receptor cell for the greater potential, and then the sensory neuron to generate the action potential, to carry it away, the information. Your book describes the taste bud as having 3 cells in it: the receptor cell, the support cell, and the basal cells that replace the old gustatory cells. But I would like you to include the sensory neuron as well. Even though most of it is not in the taste bud, some of it is. They made them both blue, so it's hard to see, but if you look closely, you'll see parts of the actual sensory neuron up in the taste bud. And it is a very important part of the taste bud. So I would count it as the 4th cell in the taste bud, or at least part of it's in the taste bud. Now, we do have different gustatory receptor cells in terms of what kind of chemicals they respond to. And we usually divide them into 5 types. We call them the 5 taste modalities. And so these include, so the classic 4, they used to talk about 4 of them: sweet, sour, salty, and bitter. Okay, those were the classic 4. What that meant was that if a given gustatory receptor cell is going to respond to one of those. If it's a sweet receptor cell, it's going to respond to sugars in your food or drink, or modified amino acids like aspartame that are meant to stimulate your sweet receptors, to make you feel like you're eating sugar. But anyway, there's the sweet receptors. Then there's the salty that respond to sodium chloride, electrolytes. Then there's the sour that respond to hydrogen ions. So if you eat something really sour, like a lemon, it's got lots of hydrogen ions in it, it's going to stimulate your sour receptors. And then the bitter would be like alkaloids, quinine, certain molecules stimulate bitter receptors, like that taste of really dark chocolate. And now there is another one that they talk about now. It's was characterized by Japanese scientists. It's called umami, U-M-A-M-I, umami. But I think that another way to describe it that's more familiar to us is it's savory. Some gustatory receptor cells respond to a savory, meaty taste. In meat, there's a glutamate. You know how some people put monosodium glutamate on their meat as a flavoring, so it's like a glutamate receptor, they think. And it's found in meat broths and things. So that's your savory or umami receptor. So a given gustatory cell is going to respond to one of those taste modalities. Okay, and oh well, here's just a close-up. You can see the sensory neuron a little better coming up into the taste bud. So presumably some taste buds can have a mixture of gustatory receptor cells, and they used to try to map the tongue, like where are your main sweet receptor taste buds and so on, but they've sort of gotten away from that because I think it's a little more difficult than they had first thought about in terms of mapping the tongue and for taste bud types. All right, this is what it looked like under a slide. Although you won't be looking, we did not look at this slide in lab. And then lastly, the gustatory pathway. What is the pathway that the nerve impulses take from the sensory receptor, the taste buds on your tongue, to their ultimate destination, which is going to be your primary gustatory cortex of your cerebrum. So that's where the nerve impulses need to get for you to perceive that taste, that sweet or sour taste. So here's what you need to know about the pathway. The main pathway is taste buds from your tongue, and then their axons travel with some of your cranial nerves. So here we see the 10th cranial nerve, the vagus, the 9th cranial nerve, glossopharyngeal, and the 7th cranial nerve, the facial nerve. So those cranial nerves carry these axons, gustatory axons. So they come up, they synapse in the medulla of the brainstem. They travel to the thalamus, and then from there to the primary gustatory area. Okay, so you may recall this from the brain, just to remind you, the thalamus is a major sensory relay center for sensory information going to the cerebral cortex. Not for smell, but for taste, and then in our next lecture when we talk about vision and hearing, we'll see that there too the action potentials go to the thalamus first, and then to the corresponding regions of the cerebral cortex. Okay, so we'll stop here for this lecture on sensory receptors.